The dentate ligaments suspend the spinal cord in the center of the spinal canal and serve to protect the brain, brainstem, and spinal cord from mechanical tension and harm during movement of the spine. A misalignment in this area could potentially transmit mechanical tension when the bones of the upper cervical spine are not in proper alignment. Hi there, I'm Dr. Kevin Leach here with the Chiropractic Deep Dive Podcast, bringing you the most important research and information on conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic care. These research reviews, interviews, and episodes are made for you, whether you're a medical doctor, patient, or concerned family member or friend. The goal of these shows is to bring awareness of the importance of taking care of our spine and the impact it has on our health and the hundreds of different health conditions it could cause without us realizing it. I'm really trying to bring value with these, so I'd appreciate commenting on the videos, hitting the like button, and sharing them with as many people as you can. You never know who might need to see it. And consider subscribing to the channel so you can see all the other episodes and videos coming out. Thank you so much. I truly appreciate your support. Now on to the show. Okay, welcome back everyone to the Upper Cervical Chiropractic Research Show. This is episode 13. I am Dr. Kevin Leach, and here with me once again, Dr. Tyler Evans. How are you, sir?
Hello, Dr. Leach. Good to see you. Good to talk to you.
Yeah, good to see you as always. So this episode, research review is titled Dentate Ligament Cord Distortion Hypothesis by John D. Grostic. This is published in the Sid E. Williams Research Center at Life Chiropractic College. So this isn't necessarily...
Out of the Chiropractic Research Journal,
okay.
CRJ.
Chiropractic Research Journal. And this is obviously a distortion hypothesis in the research. It's not, based on patients, but it's based on observation of patients and the mechanism. So let me just read just an opening statement to get everybody familiar with what we're talking about here. So in the traditional chiropractic and upper cervical chiropractic profession, we've seen for decades that our adjustments and even manipulations by osteopathic doctors and other healthcare providers have helped a significant number of health conditions. Several different mechanisms have been proposed as to why adjustments and manipulations to the spine improve these health conditions. In the upper cervical spine, also known as the craniocervical junction, the anatomy is very different and unique compared to the rest of the spine and has been thought to have different effects on the body when a chiropractic subluxation is present in that area of the spine. In this paper, Dr. Grostic explains the theory about how the dentate ligaments could be involved. The dentate ligaments suspend the spinal cord in the center of the spinal canal and serve to protect the brain, brainstem, and spinal cord from mechanical tension and harm during movement of the spine. A misalignment in this area could potentially transmit mechanical tension when the bones of the upper cervical spine are not in proper alignment, and thus create health issues due to the mechanical tension of the nerves of the central nervous system interfering with the messages being transmitted along those nerves.
It's just fitting. We're talking about the dentate ligament cord distortion hypothesis, and right behind me in the picture, all of you that are on just the audio, you won't be able to see the picture, but the guy behind me on the wall is the perfect example of what the dentate ligament cord distortion hypothesis does to the human body. And this paper came out in 1988 by John D. Grostic, the son of John F. Grostic, who was one of the founders of upper cervical chiropractic care, his father, John F. And Dr. Grostic, the first one, he developed this upper cervical technique to measure in millimeters and degrees of rotation, literally not infinitely small, but very small movements in the upper cervical spine to correct those very precisely to relieve nervous system tension. And the theory at the time was that from B.J. Palmer, who was the originator of upper cervical chiropractic techniques, modalities, he believed that the upper cervical spine clinically had shown, when you corrected it, had shown the greatest objective, observable change for the entire body. So it was the best way to correct the spine with the least amount of force and held the longest. And that was kind of the goal of this upper cervical movement. So the idea here is at the upper cervical spine, we have the most movement in the spine. In C1 and C2 under the skull, those vertebrae move the most. So when we talk about the spine here, we have 27 freely movable vertebra. And this guy right here is C1. This guy right here is C2. This is the base of the skull, right? And if you look from the side, this is what it looks like. And from the back, this is what it looks like. But if you look at it, this bone and this bone do not have, so C2 does not have a disc above it. C1 does not have a disc below it or above it. And obviously the head sits on C1. Well, what holds those together are ligaments, tendons, and muscles. And you have the brainstem that sits inside of it. And so what they're trying to describe in this paper is why patients would come in with global body problems, have a correction to the upper cervical spine, very precisely measured and corrected, and see changes all the way down to the bottom of the legs to the feet, right? Now, why might that be? Patients say it to me all the time. I kind of joke with them. It's not magic. It's not a miracle. This is science. This is neurology. It's physiology. This is biomechanics of the spine. This is biomechanics of the body. And what Dr. Grostic came up with early on was a leg check to measure the difference in the hips and the rotation of a leg length inequality is what we call it. It is not a short leg. Many people have a short leg, but that does not necessarily mean neurological interference. And so this whole leg imbalance, hip rotation, all the way up the lumbar spine, thoracic spine, cervical spine to the upper cervical joint, that's working from the bottom up, could be caused by some sort of tension between the top two vertebra and the neural canal, the nervous system inside of it. And the hypothesis here is that there are these ligaments that are very small, however, very, very strong, and they limit movement in the cervical spine. So in flexion and extension, the cervical canal moves 30 millimeters, right? So that's 3 centimeters of movement in the cervical spine. That is quite a bit. So every time, and for those of you that are not, on the video here, you can't see, but every time you flex your head down and extend your head back, inside of your bones, inside of your canal, that tissue, what keeps you alive. The messages coming from your brain to your digestive tract, to your legs, to your arms is moving a lot. And that's important because you have to be able to move, but also transmit these messages that bring life to our body. And so the problem is that if there is a small misalignment at C1 or C2, the greatest joint, the joint that can move the greatest amount, it can cause neurological insult to the brainstem, the most important part of the spinal cord, most would say, right? And that is caused by these dentate ligaments. So, Dr. Leach, you had mentioned that model that you were talking about in terms of, tubes stacked on one on top of the other. Do you want to go ahead and walk us through that, how that might work out?
Yeah. So just to give a visual and for those listening to understand what these dentate ligaments do. So if you imagine your neck and your back, and you can imagine you have bones, just like Dr. Evans, just like you showed. They're all stacked on top of each other, but then you have your spinal cord running down the very, very middle of it. Okay, so right there. So now, if you can imagine, instead of those bones, just imagine having these plastic tubes that look like donuts. Let's just say they're like a plastic donut, and you just stack those all on top of each other. that would be similar to what your spine is. Now imagine dropping a rope in the very center of those plastic donuts, all stacked up perfectly on top of each other, and the rope falls down the very center of it. Now imagine rubber bands holding the inside of the donut attached to the outside of the rope, holding the rope in the exact center of those donuts. Now, those are the dentate ligaments, the rubber bands that are suspending the spinal cord in the very center of the spinal canal. So, the cord distortion hypothesis that they're talking about here is, what if one of those donuts shifted out of alignment? Now, the inside of that donut is connected to the rubber bands. The rubber bands are connected to the rope. If you shift that donut, those rubber bands are going to transmit mechanical tension to that rope, which is going to pull on that rope. Now, that rope, being our spinal cord or even our brain stem, is transmitting messages from the brain to the body and the body to the brain. That mechanical tension, very light mechanical tension on those nerves, can interfere with the transmission of those messages. So that's the basic idea of what's going on with this hypothesis and why they're seeing these certain types of health conditions and seeing improvement in those because of this mechanism. And the pressure on the nerves coming out of the spine and the proprioceptive input interference hypotheses, although they could be still valid and causing other problems, don't explain what's going on in certain conditions like low back pain, like trigeminal neuralgia, which this paper goes into a little bit about. So, Dr. Evans, I'm going to point it back to you. Just before we started recording, you talked about the two main points for the paper. Would you go over those, and that second point being in kind of more of the tracts that are involved with the leg check and the pain and things like that? I'd like you to review that, please.
Yeah. So the paper has these challenges. They calls them challenges. Challenge 1 is that if a misalignment of the cervical spine was to affect the spinal cord, mechanical linkage must exist between osseous structures and the spinal cord. And then he goes on and explains why that might be, like we just did. That's challenge 1. Now, there are tracts within the spinal cord that would be most affected. Those two tracts that would affect the low back the most would be the spinocerebellar and the spinothalamic. I believe there's spinocerebellar and spinothalamic.
Yep.
Spinocerebellar and spinothalamic. So the spinocerebellar tract, both of these nerve tracts. So when you look, if you take a spinal cord and you slice it, which sounds kind of weird and gross, but this is what we do in neurology. We take and we basically slice right through that, and we have this picture perfect picture of what the tract systems are laid out, like a little map of the spinal cord.
Can I intervene in just for 1 second, because I have a good analogy that I've always thought of.
Yeah, go ahead.
So if you think about the spinal cord, you think about the rope that we just talked about. If you look at a rope, you'll see that the rope is made up of smaller ropes. And then those smaller ropes are made up of smaller threads and smaller and smaller and smaller. That's what the spinal cord is. So if you were to cut the rope and you look at it, you see, oh, okay, here's one of the rope, here's the other, here's the third one. And then so when we talk about spinal tracts in the spinal cord, those are the smaller ropes that make up the bigger rope. And so we have a spinothalamic that's involved, and we have a spinocerebellar that's involved. So that's a good visual, good analogy to kind of get an idea of what we're talking about here.
Exactly. And there's hundreds of them, but we're going to talk about these two and how they relate to the low back and how these dentate ligaments might be affecting them. So the dentate ligaments come out horizontally at the upper cervical spine, whereas the rest of the spine, they're actually angled a bit, and there's a lot more flexibility and play in them, where those lower spinal structures, lower cervicals, lower the thoracics and the lumbar spine don't move nearly, those vertebrae don't move nearly as much as the movement that you have at C1 and C2 underneath the skull. You can tell that by literally looking in the mirror or watching yourself in the mirror as you turn your head right and left and then turn your body right and left. Your head moves far more. And it's where those very important nerves live. So these very dense, very short and strong, they have the tensile strength of steel to hold the cord in place while things are moving. 30 millimeters of movement in flexion and extension. But that upper cervical cord cannot move much at all, right? And if it does, then we're going to have neurological downstream effects. And what we find is that C1 and C2, like we've talked about many times, can be misaligned by head and neck trauma, by concussions, whiplash, repetitive postures, you name it, birth trauma. And so all of these things may impact how that vertebra sits, and these ligaments that come out horizontally and literally pull on the areas where the spinocerebellar and the spinothalamic tract sit in the cord, on the outside of the cord. And so what happens is you're literally taking that. It's the way I explain it to people is if you have a guitar and you have it tuned, it's tuned to just the right amount of tension, which your nervous system is tuned to this correct tension all the time. But if it is too tight, the sound doesn't come out. It's not the right sound. If it's too loose, it's not the right sound. You can't get the right sound. And so what we find with this misalignment in the upper neck, it can cause this distortion in the dentate ligaments, which distorts the nerve tracts. And with spinothalamic, that nerve tract goes down and can go into the low back and cause numbness and tingling, burning, and intense pain in the low back. And that's why I know, Dr. Leach, you and I have talked about it many times, and I've seen it many times in my practice where a patient comes in with a herniated disc or some sort of chronic low back pain. We adjust their upper neck, they get off the table, and they immediately feel percentages better and slowly over time get better and better. Not every patient, not every time, but a lot of times. And so this is the reason why we might have that experience. And when we talk about research and we talk about understanding science, there are two ways to do research and science. One is inductive reasoning and the other is deductive reasoning. And inductive reasoning gets a bad play a lot, but because normally how we do science and research in the scientific world is we come up with a hypothesis and then we ask a question and then we try to answer it through research. Well, in this scenario, in chiropractic was based on inductive reasoning. We see and observe clinical data and then we come up with why that might have happened, right? And that's what we've been doing in chiropractic for 120 years. And it's worked very well for many, many millions of patients, right? Like millions of patients. And so what we know is that, we need to be able to describe that. This is one of the ways that we can do that is with these dentate ligaments. So inductively, we have created this hypothesis that we see this situation in our office where somebody comes in, the other tract is a spinocerebellar tract where their legs are torqued up, twisted on one side, their hips are out of alignment, they have low back pain, they have twisting in their lumbar spine, they have one leg longer than the other via leg length inequality, and they might have burning, shooting pain down one leg. We correct their neck, these things get better. Their legs balance out, their hips balance out. And they look at us like we're crazy, but it's because of this scientific hypothesis, right? We can induce this idea because we've seen it day in and day out in our practices.
Can you, Dr. Evans, can you explain just real quick again, maybe the inductive versus deductive and just a little bit more, like we talked about the LNTH, the linear.
Oh yeah. Well, yeah. So inductive reasoning, you see So you induce from very small to very large an idea, right? So you see clinically this thing that happens in one patient. You see it happen again, you see it happen again, and you go, that's a pattern. Okay, I'm seeing this pattern. I'm going to now create a hypothesis from these small things that add up into a large pattern. Whereas, and that's the chiropractic kind of way that chiropractic came about. And I would argue that many things in science and physics have come about that way. Most of the time in the past, great ideas came from inductive reasoning. Now we focus more on deductive reasoning, where we take, we see this broad thing, and then we try to deduce it to the very small. Like, for instance, last month, a few weeks ago, we talked about the linear no threshold hypothesis, which takes a very large problem and then throws in all these very small data points and tries to explain what's happening at those very small data points falsely. It's not true. There's no actual science behind it, right? So, not saying that all deductive reasoning is bad or wrong, but there are many instances in which inductive reasoning works very well. The Greeks did it all the time, and that's pretty much where science came from. And then, it's gone through history all the way up to us. Now we have these experimental designs, and we have the, very streamlined scientific method, which is very deductive. But chiropractic, again, we live in this world of inductive reasoning because we're clinicians and we just see things come through our office and we try to explain it with what's in the research, because we see it in our office every day. We see amazing things get better, and you're like, wow, that is wild. I never thought, I just had a patient that his atrial fibrillation got better. I've had a handful of those over the years. And every time that happens, I am amazed, right? But then I look at the literature and I'm like, okay, that makes sense. Right. Nerve tracts that are sympathetic and parasympathetic that control the heart, vagus nerve, that's all brainstem, the trigeminal cervical nucleus, it's all right there, right? So, the science is there, we just have to look. And oftentimes an inductive view will give us some fantastic information if we just dig a little bit.
Yes, that is fantastic. Will you or I could go over just as far as we talked about the spinal thalamic, right, with the pain, and so mechanical tension to that track, having messages from the lower back going through there, going to the brain. Like, obviously if there's an interference in that transmission of messages, then you could have a sensation of pain coming from below. How about with the spinocerebellar? Now we're talking about that's more proprioceptive, right? Now,
it's mechanical.
Mechanical, right? So here's my question to you. What are your thoughts on? So we have, and so here's what, and I'm sure you observe this as well, because I know you do leg checks, and I believe. I don't know if you do this or not, but there's a simple cervical syndrome test, I guess the left to right. So, I check my patient's supine, which is face up. Your technique, you do it face down. But I still have my patients go through turning the head. And so we can see when they lay down, we see a leg length inequality, right? And the idea is that it's coming from the spinocerebellar tract, right? Mm-hmm. But then you have them turn their head, and a lot of times that'll increase. And so it's like, why is their leg length inequality changing when they're only moving their head and not their hips, right? And it may even improve, meaning, implying that it's actually decreasing the tension on the spinocerebellar tract. Now it talks about, mechanoreception, it's proprioception, proprioception from that tract. Now, I check patients standing up, and we see that their hips are imbalanced, just like when they're laying down. That's what's causing the short leg. We get them adjusted, and those hips balance. Now, that mechanical tension on the spinocerebellar tract, is that interfering? I imagine it interfering with the feedback up to the brain, back down to the postural muscles, telling it how to contract. So if there's an interference there, that loop isn't happening, right? So maybe
Right.
one side of the back, the muscles are more relaxed, and that's causing the pelvis to kind of shift down, or it's too much and it's causing it to. Would that be what you would say?
Yeah, and that's what they go into, and it's a compensatory response to basically a thorn in the side of the nervous system at the area where that musculature is controlled. It's literally like, you know how this is kind of weird, gross stuff, but when they take someone's skull, the top of their skull off, and you can literally touch parts of the brain. And I don't even, have you seen these where people will smile and they'll cry and they'll laugh, and you're like, whoa, that is weird. But literally, that's what our nervous system is. It's just a bunch of input, output. This does that, and you can control it by what you turn on and what you turn off. Obviously, it's much more complex than that, but this is one place that you can have that effect, and that's why we see that. That's why in our offices for the last, since roughly 1930s, in upper cervical world, for 90 years, we've been able to do leg checks, do a correction to the upper neck, lay someone back down, and their hips and legs balance out, because we are seeing that mechanical interference release and relax, and then it takes the pressure off it takes the tension out of the neural tract. And Alf Brigg, Brigg, he wrote a bunch of medical texts back in the 60s and 70s that described this as well. So this is back before before J.D. Grostic wrote this paper. But it's very similar stuff. And I actually think one of the references here, if it's, let's see if it's in the paper, but I think that it is one of the references here. I could be wrong. Yeah, I don't see it on there. But anyways, the point is Alf Brigg, I mean, he outlined all this stuff. He was a medical doctor in the 60s and 70s and said that spinal cord tension can cause all kinds of neurological problems. And so if we know that, that just makes sense in a chiropractic world where we would want to relieve that tension and then allow the nervous system to communicate afferently and then efferently properly, right?
Yeah,
and the other, yeah, go ahead.
Well, no, go ahead. Finish your thought.
Well, I was just going to say one of the last parts of this is it does talk about how that tension can also cause. This was one of the first papers where I saw a fluid hydrodynamic discussion started, where they talk about how the venous drainage out of the cervical spine may be the upper cervical spine in the canal, actually in the spinal cord, may be affected by tension from these ligaments, where that's then blocking fluid up into the brain and causing fluid imbalances in arterial and venous flow in and out of the skull. So, there are many ways that we can explain what we do. This is one piece of it. And, for a long time, the upper cervical chiropractic was kind of, it was the early 1900s. They were explaining this problem that they were seeing with X-ray. They didn't have MRI back then, and they were explaining it with bone here, cord here, tension. There must be pressure on the nerve. Well, we know that that isn't necessarily the case. It's not just bone pushes on nerve. It's that the bone rotates, causes tension in the way the cord is actually sitting, and then that causes neural imbalances. But we also know that there are CSF flow complications from upper cervical misalignment. We know that there are arterial and venous flow complications. We know that there are proprioceptive, like you've been talking about, where the proprioceptive mechanoreceptive information that's coming from every joint, ligament, and tendon in your body to your brain, if it's disrupted, if it's not sitting in the place that it's supposed to be, it's going to tell your bad information. It's going to tell your brain and your prefrontal cortex bad information about where things are at in space. The summation of everything's going to be off, and then when it comes back out, you're going to have either pain or poor biomechanical function. And so those are the, these are the different models in which we can describe the clinical things that we see. And this is one very powerful one that this guy laid out in 1988.
Yeah, it's just amazing to think about. I mean, you can just think about it sequentially, like the spine's in alignment, everything's functioning. Just as a general statement, okay, everything's functioning normal, we're designed to function and be healthy, etc. Okay, slide that bone out of place. What happens? Well, let's start with number one. It's like,
right.
There's like mechanical, neurological.
The list is right there.
Yeah. It's nuts how many different things and problems happen that create other problems that could create other problems. I mean, it's a nightmare when you have a misalignment in the upper cervical spine and the havoc that it causes on health, and slowly and insidiously, right? Like, you don't have to go to the emergency room and get it corrected immediately, or you're going to die today.
Right.
But it causes issues over time, and it causes a lot of people to suffer. Thousands and hundreds of thousands. It's just ridiculous. It's crazy. Oh, one last thing I did want to go over, just because it mentioned it in this paper. And we know James Tomasi suffered with this. With What Time Tuesday, they talk about trigeminal neuralgia and why this hypothesis could explain why patients with trigeminal neuralgia could get help. And it's that, like you just mentioned it before, the trigeminal cervical nucleus that goes down, down possibly even to the fourth cervical vertebra. That nucleus could go down in there. So any mechanical tension on the cord interfering with that could obviously cause symptoms in that, in the trigeminal nerve, which would be the trigeminal neuralgia. And I think Dr. Grostic explains that it was the specifically anterior rotation, for whatever reason, anterior, not posterior, that caused an interference in that, he emphasized when that needed to be completely corrected in order for his patient or patients to get that relief from that trigeminal neuralgia. I thought that was just interesting. So.
Yeah, it's trigeminal neuralgia is terrible, and it's dubbed the suicide pain, and that's not really the topic of our discussion here. But again, people wonder why would that get better by adjusting my neck when the pain is in my face? And it's just, we try to describe it to every single patient that comes into our office, is that oftentimes people come in with misalignments in their spine, in their upper cervical spine. Not always do the symptoms appear, and very rarely do the symptoms actually appear at or close to the place in which the neurological trauma is happening, because that is the way the nervous system works. It's upstream, downstream, all day long. That's what your nervous system is doing. And so what we find is that people come into our office, and your office, I'm sure, where they've been to lots of different people who have worked directly on the area that hurts, but oftentimes that problem will get better for a short time. Then that problem comes back, and it comes back, and it comes back. Why is that? It's because you're not getting to the root cause of the problem. And C1 and C2 misalignment are oftentimes a root cause for a lot of different things, and are not always the only root cause, but are a piece of it, right?
Absolutely.
Yeah.
Absolutely. All right. I know in the paper here, there's a diagram with the corticospinal tract, dorsospinocerebellar. Do you want to get into that, or do you think what we've gone over is sufficient?
Yeah, I mean, I think we kind of covered that, but the picture in the diagram is not the best. It was drawn and published in 1988. So, you
1988,
know,
yeah.
it's not the best graphic, but I mean, you can look that up online, look up the dentate ligament hypothesis, and you'll actually see a lot of updated information. There's actually some pictures online that that show a actual cord slice and then where the ligaments attach, and it's pretty neat to see that. And you'll see where the tension can be placed and where the nerve tracks are actually at, in like a live specimen. That's pretty easy to find if you look up dentate ligament theory and chiropractic. It's pretty ubiquitously out there. I think before we go, I just wanted to touch on the fact that there are other ways that we found since then that might also coincide with this, where there's actually other parts of the cervical spine that have direct neural impact via the myodural bridge of C2.
Oh yeah.
There's the Y ligament, was described just a couple of years ago, actually, where it attaches from somewhere around C1 or C2 into the cord again, and a different one, right, other than the myodural bridge. And these are literally, you have bone, and then you have ligament into the cord, right? So bone moves, cord moves, right? And we don't want that, right? So we want the least amount of that as possible. There should be a proper biomechanical movement where it's not interfering with the nerve function. So there's many different plausible ways we could describe this, but the dentate ligaments and the myodural bridges are one very easy way to do that.
Right. And just to clarify, when we move, and all those connections are designed to be supportive and structural when we move with proper biomechanics, not to have tension on the cord when we're just in a neutral position or not moving and putting strain on the cord. And that's that long-term tension on the brainstem and spinal cord that can create an issue. So
yeah, it's I remember in school there's a I believe it was just a research study that said that a very small amount of pressure on a nerve can actually, or tension on a nerve can affect it quite a bit. We called it the weight of a dime study.
I heard that too, and I'm curious what the
I have the somewhere deep in my hard drive. I have the research study that came from that.
Okay.
And it was like, I forget, but they measured it, and it was basically equivalent to the weight of a dime. Over time can cause neural decay and neural dysfunction. And I mean, that makes sense. If you took a dime and laid it on your spinal cord over time, you would very quickly lose function, right?
Yeah.
It's just not meant to do that. And then this is when we talk about health, right? What is health and where does it come from? And are we truly healthy? Who's checking the nervous system to see if it's healthy? I don't know anyone outside of chiropractic that does that. You know, obviously neurologists look at brain scans, they look at those things, but they're not looking at how are the nerve signals coming out of the brain and going into the body. You can do a neural, is it needle EMG, but great, how do you fix that? I mean, I have a chiropractic study by Kirk Eriksen. You and I have a chiropractic study by Kirk Eriksen, guy who studied under J.D. Grostic, who had a patient with a cervical disc herniation, numbness and tingling into their arms and hands. Neurologist diagnosed it and identified it with a needle EMG, where there was literally no signal coming out, or very little. And so the hand was going numb and tingly and had pain in it, and then corrected C1 and C2, and that lower cervical problem got better, nerve function came back, and the needle EMG signal cleared. That's awesome science. That's beautiful. You know, so that's what we're talking about. We want to remove these neural interferences.
Yeah, I think you hit the nail on the head, and it's so important to understand. And I feel like patients, the public, and really nobody really knows how we overlap. Now, you talk about who's checking the nervous system, and you said, okay, you know, neurologists. Well, typically neurologists are going to be working with people with tumors, people with, upper
MS.
motor neuron. Yeah, like these really bad neurological things, not back pain, which
Right.
we obviously link back to being neurological and having being affected by the nervous system. So it's really important for the public to understand that we need to understand, we need to work together. Obviously, upper cervical chiropractors and neurologists, we need to work together.
Definitely.
And we have to understand who does what, and that we can actually screen these patients and be able to triage and refer these patients if they need it. If they need to get to that, we can be that primary spine care doctor, and we can recognize like something's going on here. You need a referral here. We're not just going to adjust you and shove you out the door. That's important.
Yeah, and they're busy. Like we have a neurologist here that I've made a relationship with, and he is slammed all day long, and he doesn't have enough time to like really get to the bottom of a lot of this stuff, or he doesn't feel like he can. So he refers patients to us, and we refer patients to him.
That's what needs to happen.
Right.
When they do their exams and they don't find anything positive or significant, but the patient's still having issues, they need to refer to us.
Right.
And
we can refer to them.
Exactly.
And vice versa.
So working together. That's how proper healthcare should be done. Anyway,
Totally.
I know you have to go, Doc. You got patients, I think, very soon here. I appreciate you. I appreciate your time, and we'll see you next episode.
Yeah, good talking.
Awesome.
Great paper.
Thanks, sir. Take care. See ya. Okay, that's it for this episode. So what did you learn that fascinated you or surprised you about the research today? Join or start the conversation in the comments below. Hey, thanks so much for watching. To watch more of our research shows, click or tap the screen right there. To subscribe to the channel, click or tap the screen right there. Until next time, I'm Dr. Kevin Leach with the Upper Cervical Chiropractic Research Show, bringing awareness to conservative primary spine care, upper cervical chiropractic care, and traditional chiropractic. Until next time, take care and take care of your spine. It's the only one you'll ever have.